to all of you. I am Dr. M.D. Arifur Rahman Chaudhary, Registrar, Physical Medicine and Rehabilitation Department, Dhaka Medical College Hospital. Welcome you all on today's live scientific webinar on JAK inhibitors in rheumatoid arthritis, current update. Today, our scientific partner is Delta Pharma Limited, and our keynote speaker is Dr. Mohammad Moniruzzaman, sir, Associate Professor, Physical Medicine and Rehabilitation Department. We have our expert panel. First of all, I would like to introduce Professor Dr. Zahidul Islam, sir, Department of Physical Medicine and Rehabilitation, Dhaka Medical College Hospital. Professor Dr. Monir Islam, sir, Head of the Department, Physical Medicine and Rehabilitation Department, Sir Solimullah Medical College Hospital. As guest of honor, first of all, Professor Dr. Syed Muzaffar Ahmed, sir, Department of Physical Medicine and Rehabilitation Department, Bangabandhu Sheikh Mujib Medical University, and Professor Dr. Shahadat Hussain Ripon, sir, Vice Principal and Head of the Department, Shohid Sohrawardi Medical College Hospital, and General Secretary, Bangladesh Society of Physical Medicine and Rehabilitation. As the whole session will be chaired by our Professor Dr. Sohail Rahman ma'am. Without any delay, I would like to request, with the permission of our chair, Dr. Mohammad Moniruzzaman, sir, to present his topic. Thank you. Sir, please unmute first.
আমার স্লাইডটা কি শেয়ার হয়েছে?
হয়েছে স্যার।
আচ্ছা। Honorable Chairperson, my professors and teachers, and also the colleagues and junior students, Assalamu alaikum. Today's welcome this live webinar on the JAK inhibitors in rheumatoid arthritis current update. Now, my disclaimer is that this is sponsored by the Delta Pharmaceuticals Limited. Our learning objective is the understanding the RA pathology, the latest treatment guideline, the correlation with the RA pathology and the mechanism of action of the drugs, JAK inhibitors, the pros and cons, and choosing right drugs in right person, and no new terminologies. The first of all, I want to just go through some cases. Case 1, regarding the assessment of the rheumatoid arthritis. In laboratory test, ESR 27 millimeter, CRP 9 milligram per deciliter, rheumatoid factor negative, anti-CCB negative, and 1433 eta positive. This is a new biomarker. Radiographs of her hands and feet shows no erosion or joint space narrowing. So CDI score 8. This is a new molecule I already mentioned, and there is a CDI score 8. That means I will actually after thorough my lecture, later I will discuss about the cases so that everybody can understand. Case 2, in established RA, this is a man with rheumatoid arthritis of 2 years duration had been doing well on oral methotrexate 20 mg weekly, presents with increasing pain in his hands and feet over the past 3 months with 30 minutes morning stiffness and 8 swollen and 10 tender joints, and CDI score 21, ESR 45, CRP 2.5 milligram per deciliter, and ACPA and RA positive, and baseline MBDA 1 year ago 38 and current score 52. This is another new biomarker. Radiographs do not show erosion or joint space narrowing. And case 3, I already mentioned, this is another biomarker. Case 3, Eriksha Puller, 35 years, polyarticular arthritis, failed triple conventional synthetic DMARS therapy for the last 6 months and swollen multiple small and large joints. I want to highlight that this triple conventional synthetic DMARS therapy actually failed in this case. Now, actually, we do not discuss about the history. So just I put some few words in my slides. In 1642, Dr. G. Bailau, a French physician, emphasized that the arthritis could be a systemic disorders. 1782, William Haverden discovered digital notes. By his name, we use the Haverden's note, but it was actually uttered by him in 1782. In 1859, Sir Alfred B. Garrod attempted to introduce the term rheumatoid arthritis. In 1904, Dr. Goldwaite, an orthopedic surgeon, makes the first attempt to classify arthritis into 5 categories: gout, in-fascia arthritis, hypertrophic arthritis, atrophic arthritis, and chronic venous arthritis. And in 1983, the American Rheumatism Association, they classified the 10 major categories. Everybody knows these terms. But now actually for easy understanding, I just divide into non-inflammatory and inflammatory. And the rheumatoid arthritis, of course, is under the inflammatory arthritis. So it is actually common, very common in our population, affects 3%, and female is greater than the females to male ratio 3:1. And rheumatoid factor positive in 80% cases, and HLDR4 in chromosome 6 allele, and mononuclear cells are the cellular mediators of tissue destruction. The biomarkers in RA, that is actually the most common, we see the rheumatoid factor and the ACPA, or the anti-C20 peptide antibodies, and the acute phase detecting ESR and CRP, and new biomarkers, the MBD and the 1433 eta. And the 2010 ACR Euler RA classification criteria, everybody knows, just the more than 6. And in advanced stage, you see the joint destruction, deformity, instability, and of course the pain, and these button wear or the swan neck, and actually the whole hand is actually totally deformed and disabled. Now the pathophysiology. I am trying to pathophysiology slowly so that everybody can understand, because we actually go very fast. So within one slide, so I make the few slides for better understanding. You see here, this is actually the synovium, hypertrophic synovium. This is a space, tubular space. This is a cartilage, bone. This is a synovial fluid here, and I magnify here so that we can discuss about what are the going on within this. You see, these within the synovium, these are fibroblast lining here, and there is a macrophage. They secrete the cytokines and intermediates, that means TNF alpha, interleukin 1/6. It actually stimulates the fibroblast to secrete the rankle, and this rankle and also these cytokines, this also stimulate the osteoclast for bone erosion. And it also stimulates this fibroblast to secrete the protease. That protease actually also can destruct the cartilage, responsible for the cartilage destructions. And you see, this actually the why the macrophage is coming, or the neutrophils, or the other immune cells, because the precondition is actually the genetics and the smoking and the unknown antigens, suppose gingivitis. These actually modify the autoantigen, and including the citrullization. And after involving the citrullization, actually it also by triggered by the infection or the injury. This continuously triggered the actually the modification of the autoantigen for the citrullization. And for this citrullization, actually the APC, antigen presenting cells, it become activated, and it migrate to the lymph node. And in the lymph node, you see this actually activates the T cell, and this T cell co-stimulate the B cell in the germinal center. And this B cell transformed into the plasma cell. This plasma cell actually produce the huge number of the autoantibodies. And this activated T cell also produce the CD4 T cells. And this CD4 T cell also migrate to in the blood. And this huge number of autoantibodies, these also migrate into the blood vessels. And these causes actually for the angiogenesis, increased vascular permeability, and adhesion molecules. That actually these leaky vessels actually within the synovium, there is a rich of plasma cell, macrophage, and CD4 T cells, and also the inflammatory mediators. And you see in the blood, among the antibodies, actually the rheumatoid factor and the anti-CCP. This rheumatoid factor actually the IgM at the 75%. This actually targets the FC portion of the IgG, and it forms the actually immune complexes. So continuous formation of the rheumatoid factor and targeting the FC portion of the IgG, there is actually memorize our immune system for the chronic inflammation. And anti-CCP, you see, it also target the CYP-related proteins such as fibrin. And for this permanent or the persistent, actually the streaming of the inflammatory mediators in the blood vessels, actually that causes the extra-articular manifestations like the skin nodules, or in the liver produce the ESR, CRP, or the increase the hepcidin that causes the anemia, or even in the vessel, especially in the heart vessels, or the central or periphery, these inflammatory mediators causes the vessel injury. That vessel injury actually invite for the atherosclerosis. Actually, in grossly, we think hyperlipidemia is the main cause. Actually, not. No. The persistent inflammatory mediators that causes the injury to the vessel, and that injury actually the invite the actually the cascade of the atherosclerosis. And you see that in the neuro and in the brain, there's actually chronic anemia causes the fatigue and depression, and osteopenia and osteoporosis, and insulin also the insulin resistance develop and the muscle weakness ultimately, and in the bone marrow there is a thrombocytosis and also the anemia. So these are in short actually the total pathogenesis A to Z. And now the rheumatic treatment, actually our motto is just to stop the synovitis and rest by rest, and the drug by the DMARDs of the biologics. And in the end stage, the synovitis may be chemical or radiated or radiation by the surgical, and prevent deformity by the splint test, physio, or the tendon repairs, joint stabilization, and reconstruct the arthroplasty, arthrodesis, osteotomy, and arthrotextual surgery in arthrodesis stabilization, and rehabilitation by the occupational therapist, aids and support, and physiotherapy headed by the physiatrist. And overview of the treatment of RA, actually the last few decades, tremendous actually improvement of the RA therapeutics, but still actually we have no cure. Each drug have actually the many side effects. We are worried about the during the precision, or also the patients or not. And you see the before 80, there's the NSAID, steroid, and gold salts, and the pain. The treatment objective was the pain stiffness, and the principal is actually the symptom elevation. But between the 80 to 90, the conventional synthetic DMARDs combo therapy, there's a above objectives. There's a pain stiffness plus structural damage reduction, and the principal is the total joint replacement postponement. And in 2000, there's a TNF blocker, and a remission of the structural damage blockade, and early diagnosis, early treatment to target and tight control. In 2010, the multiple biological DMARDs and the target-specific DMARDs, and the actually objective is comorbidity management with the others previous objectives, and prevention of the all disease sequence, reduced mortality. These are actually the DMARDs nomenclature. This is the latest 2019 update in the EULA recommendation. This is our method is said the sulfasalazine under the conventional synthetic DMARDs, and the targeted synthetic DMARDs actually the baricitinib, tofacitinib, and the upadacitinib. These are synthetic DMARDs. And under the biological DMARDs, they categorize the two biological originator DMARDs. These are actually the all biologies, the adalimumab, citrusumab, etanercept, the infliximab, and the sarilumab, tocilizumab. And the biosimilar DMARDs is actually currently adalimumab, etanercept, infliximab, and rituximab. Later I will say, you see the RA treatment goals in the 21st century, actually the early diagnosis, early treatment, and the tight control in the follow-up, and the time to aim remission, and patient-centric approach, and treating the whole patient comorbidity, psychological issues. And in simply DMARD start usually by methotrexate and bridge therapy. The target is decrease up to the DAS 28 less than 22.6, and if we achieve, we continue the MTX. But if more DAS 28 more than 2.6, we have to add the sulfasalazine and hydroxychloroquine. Usually at this stage, actually there's one poor prognostic factor actually is few responsible for not responding to the monotherapy of the methotrexate. And after adding this triple therapy, many cases actually managed and to the dust rate less than 2.6 and continue this triple therapy. And if not managed, that means dust rate 2.6 to 5.1, change the MART or they add low dose penicillin, and more than 5.1 if they add the biologics. And this good prognostic factor is actually moderate to high disease activity, high SRCRP, high swollen joint count, and positive RA and anti-CCP, and early erosion and the failure of the more than 2 dimers. Now the treat to target strategy, because this is a after 2000, we actually our objective is included this treat to target strategy. The treat to active RA, this is actually the update in 2020 NICE guideline. The target of remission or low dose activity if remission cannot be achieved, and consider making target remission rather than the low disease activity for people with an increased risk of radiology progression. In active RA, monthly measure the CRP dust rate in practice. That means you see if MTX is failed, then hydroxychloroquine can be tried. And in leflunomide and sulfasalazine for mild or palindromic cases, and sarilumab, a newly added for moderate to severe RA. And you see, there's a we found there's a the high risk factor. That means initially we get the bone joint erosion, remote factor, and the high CRP or the high anti-CCP and high disease activity. So in this case, the fast tracking the early rheumatoid arthritis, we can go through by the DMARDs combination or the biology DMARDs plus MTX or MTX monotherapy and glucose bridging. And it is potentially rapid. This prevention requires frequent therapeutic efficacy monitoring in the post-diagnosis phase 3 to 6 months. This is very important. Until the remission, there is a monthly follow-up is necessary. And dust 28 everybody knows, and also we have apps. And monitoring, the history exams and some blood, the renal function and the liver function test. But lipid profile, I actually making the red color because it is sometimes our physician may miss, because the many biologics increase the causes the hyperlipidemia or dyslipidemia, and the latent TB should be excluded, and the yearly tests should be done, even the latent TB absent. And the antiphospholipid antibody also should be checked in the pregnancy, anti-la also. And synovial biopsy is sometimes need in case of refractory monoarthritis or the monoarticular presentation of the RA, or the all joints is managed except one. In this case, for further evaluation, we do the synovial biopsy. This biopsy is also important for the new invasion of the drugs. We also practicing you see the sono-guided. I pick up the synovium for the biopsy, and you see these a 2020 American College of Rheumatology guideline for the reproductive health. You see in remission, they say the ACR eular remission definition Bolen or index based. So what is Bolen based definition? You see, at any point of time, patient must satisfy tender joint count less than 1. Very easy. You see, this swollen joint count less than 1, CRP less than 1, and patient global assessment 0 to 10 less than 1. So not to memorize, not to make any chart for research. And Bolen based definition, they have also suggestion, because patient may not have this report. So without the CRP, we can just count tender joint, swollen joint, and patient global assessment. This is an easy, quick way to approach as for the find out the remission. And index, this is CDI also less than 2.8, because this CDI no need to CRP. And the dust data I already mentioned is the actually for the research, because this need. You see, this is a Bolen based definition I already mentioned, but Bolen based suggestion for clinical practice, they omit the CRP. And index based suggestion for clinical practice, they use the CDI, because here CRP is not, or the no blood report. And see the elements for the features, the fatigue and imaging. These are because there is no boundary and there is no actually specific variable or the we cannot digitally categorize. And imaging also, because there is a many I am very fond of muscular ultrasound, so I show you. You see, this is hypertrophic synovium, and these are high vascularity show in paradopular mode. By sono, we can categorize the grade 1, grade 2, grade 3 synovitis. These are books for the in physical medicine, reproductive medicine for muscular ultrasound. And you see the ultrasound in RA continuum. Then they try to find out that even the remission criteria less than DAS28 less than 2.6. The ultrasound shows the part of a signal. So the recent published the review books or the article, they mention the multidimensional remission. They proposed, hopefully in future, this term may be included in the guideline for the including the sono evidence of the remission also. And the concept of immunological tolerance, this is very also important for the remission, because what do you mean by remission? Actually, we think this is good control. Actually, when the remission is going on, we actually taper our DMARDs, NSAID, steroid, and ultimately the few years the patient may be totally in remission. But here is, as you know, that there is no cure. So the cure means actually the reintroduction of the immunological hemostasis or the immunotolerance. But this immunotolerance actually does not mean a mere lack of response. It means actually not to react immunological defense reaction when they are not needed. That means actually the overreaction of the immunological defense that causes the chronic persistent inflammation. But we do not want the overreaction. So this is when there is no extra reaction of the immunological defense. This is called immunological tolerance. So persistent control, good control of the immune system by the DMARDs or biologics. Our target is to go to the immunological tolerance. The daily life burdens with arthritis, you see, there's a functional impairment, pain, fatigue, and inability to participate in family, social, and leisure activities, and reduced productivity. These are actually the burning issues. And this is also actually burning issue for the physicians. You see, there's the unmet needs for the many flares in the lifetime. You see, the last 10 years, there is a minor flare, major flare during the treatment of the rheumatoid arthritis patient. And in some patients, dose reduction may result in resumption of the disease activity. You see, dose reduction group 88 flares, but usual care group 16 flares. That means when you try to reduce the dose, there is many flares. But if you do not try to reduce the dose, actually less flare. So very careful selection of the remission criteria and decision for the tapering. So even for the first choosing the right pro-inflammatory drugs, it is also actually the credit for the rheumatologists and also the physicians who actually care the rheumatology patient. I just make a picture like Ferraris. If we sent out without maps, and we should not actually at the end of the day, maybe the wheels have disappeared. So with many calculation, we maybe plan that we add the 2 DMARDs or 3 triple therapy, but maybe the ultimately 1 month maybe fail. We can switch to the biologics. So actually so choosing the right drugs for the right person definitely is actually the good practice and experienced. And we hope actually our trainee should be able to choose the right drugs for the right person. Here actually these are very clumsy actually the many pathophysiology, many actually the immunological terms. So I just a little slide, a few slide I bring for the in our childhood. Actually in village you see some in the because actually in urban area we do not see this type of picture now. So it's actually the maybe you nostalgic, and for the refreshing brain, just I go through some few slides. You see now the biological agents or the biological DMARDs. The biological agents actually targeted towards the specific cytokines and other cell surface molecules regulating the immune response. And it is actually it's biotech medicine and obtained from a genetically modified living organism. And actually these all are biologics, actually the monoclonal antibody, and they have to pass different step to form a big or complex molecules, and ultimately they are actually the inhibit the specific cytokines, but the biosimilars is actually the very close to the biologic drugs but not biologics, because this is not originator but should have fulfilled the all criteria of the originator molecules. And so how I confirm the biosimilar fulfill the criteria of the original molecule. So for this reason the recognized or the well-known institution actually the backup or they accredited the drugs like the EMA, European Medical Association, or the European Middle East African Association. If they suggest this drug is biosimilar, that means more close to the original molecule, we can agree these are biosimilar drugs. But in Indian subcontinent, we have no biosimilar drugs. Though we are using the drugs as a biosimilar, but actually not. I will show just one slide or few slides later the evidence. You see, these are 4 steps. Ultimately, there is a big molecule formed in case of biological drugs. And so to making the biosimilar drugs, actually we want the correct folding and the subunits into the quaternary structure and glycosylation. But the unwanted is there may be chance in incorrect folding, aggregation, and amino acid modification. And this may be chance if there is a strict follow-up in the actually the pharmaceutical company. There's maybe chance of like this. And if there is a changing, there is the performance or the outcome or the control of the maybe the change. Though the phenotypically the drug is same. So why the biosimilars come out? You see, these expiration of the biological agents. They expired. You see that the abatacept expired in 2019, but also you can see rituximab is already expired 2016. So all drugs in the rituximab in the developed country, they actually use the biosimilar. Biosimilar is a little bit cheap, but it's close to the original molecules. And many company can produce this rituximab as a biosimilar. But in our surroundings, we actually found similar biologies, not biosimilar. You see, there's in Indian government, you see, there is announced on 15 September 2014, US-based biologist company Epirus Biopharmaceuticals announced on 15 September 2014 that it had received finally approved as it is infliximab similar biologics. It is not biosimilar, because they know that in India or in South Asian setup, there is a very difficult to maintain the quality of the like biosimilar. So the term use a little bit change. And the biobetter is another term. This is actually for the some in unwanted matters making the biosimilar. Sometimes the drug performance is more than the original molecules. Then it is called the biobetter, not biosimilar. Sometimes it may be happening. So what to do before giving the biological agents? Everybody knows actually that we should check out the all basics investigations and exclude the infection. And regarding the vaccine, the recommendation is you see the life-threatening vaccine should not be given in herpes zoster in case of anti-TNF biologics or the non-TNF. That means all biologics in case of life-threatening vaccine should be prohibited, especially for the herpes zoster. But the other vaccines, that means pneumococcal influenza, hepatitis B, and human papilloma can be given. And use of the biological agents, you see the anti-TNF, anti-B cell, and the inhibitor of the T cell, anti-interleukin 6 and interleukin 1. All are actually the recommendation actually is ongoing now. And now the kinases, to understand the pathophysiology of the kinase system, we can easily understand the which level of the drug actually act. You see these receptor and these are cytokines. There is and the cell membrane, and this is a intracellularly JAK molecule actually work here. And you see, the JAK actually the 4 receptor, JAK 1, 2, 3, and the tyrosine kinase 2. And the JAK inhibitor actually works on the on few receptors. But the biologics, the interleukin-1/6 inhibitor or the interleukin-10 or interferon gamma or everything, actually they are single molecules and biologics act against this so that it cannot bind here. But all molecules actually work through the JAK system, because the JAK system is fully responsible for the transmission of the signal from the cell membrane to the nucleus. So, but the oral molecule that JAK inhibitor when come out, actually this is a better act rather than the single biologics, each different cytokine receptor, because it commonly inhibit the JAKs. You see, just I show you. This is actually the cytokine receptor. There is a bind with the receptor, and after binding, the JAK molecule actually come out and activation through the phosphorylation. And after activation of JAK phosphorylation, this actually invite the stat, and this is a stat, and this is a active JAK. By this way, they make actually the dimer form, and this dimer actually move toward the nucleus for the transcription of the RNA, for formation of the amino acid. And this amino acid actually cytokines, they produce the huge cytokines, pro-inflammatory cytokines, and this come out from in the cell membrane, then from the cell to the bloodstream, immune cells, the antibodies, lots of. So if the biologists act over here, the anti-TNF or the interleukin-6 inhibitor or the interleukin-10, but JAKs act over here. So whether the receptor, the JAK system block everything, but the different biologists only block the different cytokines. So other cytokines is active in case of the biologics, but in the JAK inhibitor actually inhibit the most of the many cytokines system. So for this reason, the JAK inhibitor actually also the side effects are also the more, because our also some I will show you our some anti-inflammatory cytokines also helpful. Suppose interleukin-4, interleukin-10, these are the very good anti-inflammatory cytokine. These also responsible for our helping the defense system in our chronic. Continuously we are exposed to the environmental antigen, but this system also blocked by the JAK, because JAK universally in the tofacitinib or baricitinib, universally block the JAK system. So for this reason, the natural our anti-inflammatory cytokines also the blocked, but in the biologics actually the only the single receptor actually blocked. So for this reason, actually the tofacitinib or baricitinib, they are actually the recommendation. If even the biologists may, if the fail or moderate to high, we can use the tofacitinib or the baricitinib, and the safety consideration also is important. Before prescribing drugs, we should see whether there is any infection or any new infection is coming. And between the baricitinib and the tofacitinib, this is another question. Is there any superiority or not? Actually, there is no superiority, but the tofacitinib initially thought that it is actually inhibit the JAK3 receptor, but nowadays it is also block the JAK1 and a little bit JAK2. But baricitinib actually the JAK1 JAK2 inhibitor. So it is we can call this a second generation, more safety margin rather the tofacitinib. And you see these I already mentioned interleukin-10 and interleukin-4. These also blocked. We do not expect that it should be running, but in case of JAK inhibitor, it is also blocked. And other new molecules also incoming. And I already mentioned the moderately severe active RA. Actually, this JAK is used, and some trial also already published. You see in the baricitinib methotrexate or in combination. You see the ACR 20, 50, and even in 70. This is the baricitinib 4 mg or baricitinib methotrexate combination. These are actually the very much close to them, but the only methotrexate is a less response. And another trial is RA.Current trial. Here also you see the baricitinib 2 or 4. 4 is more, show the more response. And the baricitinib 4 and adalimumab, here also baricitinib shows the superiority over the adalimumab. And the biologics and pregnancy, there is also another issues. You see, in case of actually the many biologics can be given in the pregnancy, like you see the infliximab, etanercept, adalimumab is no problem, even pre-conception, during pregnancy, and the breastfeeding. But the tofacitinib or the baricitinib has no data, so we cannot give. And even in the male person, we if any male we become planning for the father, so there is also unable to recommendation for the limited data is not recommended. Only thalidomide, there's a 4 weeks ago, thalidomide should be stopped before planning of father, and the cyclophosphamide for the 3 months before they should be stopped, and others as can be continued. And in the COVID situation, JAK inhibitor is also another issues. You see the glucocortic in general, glucocorticoid, if the glucocorticoid is continued in RA patient, it should not be stopped. And an AC inhibitor should be continued, or if not started, it should be continued, because AC inhibitor also help to block the internalization of the COVID virus. And a stable rheumatological patient without COVID in pandemic area continue the previous treatment. In SLE, hydroxychloroquine continue. If indicated, belimumab can be started. Newly diagnosed rheumatoid patients without infection, the steroid 10 milligram, less than 10 milligram, except lupus nephritis and vasculitis, that in this case high dose steroid may be started, should be started. And ongoing treatment with stable patient with asymptomatic exposure, that means no symptom, the stable rheumatoid patient, the all drugs should be continued, but the steroid or the biologics should be stopped, because there's a as there is exposure but no symptom, but there is a chance of COVID. So the surface allergy or the NSAID can be continued, but not steroid, JAK, or the methotrexate or leflunomide. And with infection rheumatic patient, hydroxychloroquine can continue, but other all drugs should be off. Mild symptom, NSAID can continue, and severe respiratory distress, NSAID should also off. But interleukin 6 inhibitor, that means tocilizumab, can be started or continued, but it needs the shared decision with the expert. And reinitiating treatment, that means for the COVID, 2 weeks, 3 weeks off all disease modifying drugs or the biologics. So when we should start? That is, they recommend the ACA recommend 7 to 14 days after recovery of the sign symptom, or asymptomatic PCR positive test. Then in that case, the restart after 10 to 17 days positive test. And after severe infection, it also should be take decision with the group meeting. And so I already mentioned the fatigue and imaging. This is actually the unmet condition. Despite the intensive treatment, unacceptable levels of the fatigue persist in many rheumatoid patients. And clinical trials, both methotrexate and biologics, actually fail to produce meaningful improvement on fatigue. And a substantial majority of RA patients cite fatigue reduction as a key treatment goal. So in Sports Medicine Journal, they also find out the pain, fatigue, and mobility, and they try to overcome by the symptom management, pain relief and distraction, and the joint function, with controlling the biomarker level and phenotypically and genotypically. And the RA patient-centric approach, this also should be concerned by the physician, because the paternalistic decision making, this not actually we do not expect, because this is a old style. You see, I was just in such bad shape. I thought I got to do something, so whatever they suggested, I thought I would try it. But the shared decision making is, well, as I learn more and have become more comfortable talking about medical issues, and particularly the disease that I have, yes, I expect to be treated like the intelligent adult that I am, and not just be told, here, take this pill and it will be good for you. So actually, patient, if we educate the patient, so shared decision is easy. These are rheumatology model. They have a 7 days program, and they have a rheumatologist, physical fitness specialized psychologist. They treat and educate the patient about the adverse effect, follow-up like this. And rehabilitation, you see, the the orthosis, making the range of motions and the many aerobic exercise, because without rehabilitation, no treatment would be completed. Now we come back to the first few slides, the case one. I already mentioned, you see, there is these new molecules actually now are actually in articles there is coming. Actually, these molecules actually in the article shows if they are negative, but if positive, it means the disease process may be more aggressive. But the RA positive, NTCG positive, and the ACPA positive, there is a more chance of more aggressiveness. And CDI, I already mentioned the CDI actually may be used in the clinical settings. So CDI score the 8, it is a more because our target is less than 3.3. In the established RA, you see here also you see the CDI 1021, and now we understand this in clinical setting. We can understand that there is a huge aggressive because many polyarticular joint we cannot manage. So it is a more than 6 RA criteria, and though there is no erosions, so we understand. But here you see there is a last 2 years there is a monotherapy already gone, but the last 3 months there is monotherapy is not sufficient. So we can add here double or triple DMARS, and for the 1 month or 2 months, if not response, then we can switch to the biologics. And in case 3, you see, I actually want to emphasize on the risvopolar, because in case of triple therapy, when there is no JAK inhibitor, we have only option of the biologics. But this risvopolar or in Bangladesh, many patients have not able to buy the biologics. So actually, is a blessings for invention of JAK inhibitors, because now they can buy with costing 24 or 30 taka, and the baricitinib also the more cheaper than the tofacitinib. And also I want to mention the JAK inhibitor molecules have a short half-life, and it no need the refrigerator, no need the saline, no need to hospitalize, no like the biologists, no need to special team, and but only the oral tablet, and block the long, actually the common pathway, and only we are worried about the more side effect or the infections about this. But for this we should educate the patient. The summary and conclusion: the last few decades actually extraordinary advancement of the understanding the pathophysiology. Physicians, rheumatologists should be updated always with upcoming the guidelines, and physicians always take care not only to pathology but also to our patient social status, and monitoring, reviewing, educating the patient, and focusing on fatigue, pain, and disability, and keep our eyes on adverse effect of JAK inhibitors. And however, patients still have unmet needs, and a cure remains elusive. Yesterday I got email from the Association of the Academic Physiatrists. They started the program for academic leadership, 3 years program. They actually for their academic meeting, they every year they make this program for 3 days. 1 year for the administration, second year for the clinical practice, third year for the research. So they invite me as an international physiatrist. So it's my honor. And this is another picture of you see, you understand this is African in the COVID situation. And in the mid slide, I show you in the rural area, there is in our childhood, actually we are playing a lot. But in Corona situation in urban area, you see there is online classes. The grandmother or writing or attending the classes in lieu of the child, because the child is not attentive. And also in practices, we have to be more concise in the PP. Now, so this is I try my best to simplify the JAK inhibitors or the biologics or the treatment protocols for the choosing the drugs, so that our trainee or the students can be more easier for them, especially in the Corona situation, because we have not time to expose directly to the patient in the outdoor or indoor. Now the Eid al-Adha is coming, So সবাইকে ঈদের শুভেচ্ছা, সবাইকে সালাম। আসসালামু আলাইকুম।
Thank you, sir, for your brilliant and informative presentation. It was an informative one. Now the program is open for all participants for an open discussion and question answer session. Thank you. Sir, one of our participants, Dr. Amir Islam Sijar, IMO, Physical Medicine Rehabilitation Department, questions a question that can we use baricitinib in juvenile rheumatoid arthritis?
Thank you, Dr. Aminul. Actually, the below 10 years, or below 15 or 16 years, actually we did not get any data. The baricitinib only used in the adult and not in pregnancy, and also only in adult we get the data, because only the very recent this come out in the market. Without evidence, we cannot use in the juvenile case or like this.
Thank you, sir. Another question, is there any effect on kidney by using the JAK inhibitors or JAK inhibitors?
Yes, actually the many biologics actually maybe use the less than 30 or 40 GFR, but here is recommendation less than, not if less than 60 GFR, the JAK should be. That means 1 or 2 we can use in CKD, not 3.
Thank you, sir. Another of our participant asked about the duration of the treatment by JAK inhibitors.
The data is actually we found highest 7 years. The baricitinib because we in the article and in the developed country, that means USA and Europe, the baricitinib actually found in 2016, and before coming 2016, the trial is many trials over the many level. So total about the 7 years we have data. There is a no safely we can use, but the case selection is very important. If the case selection and judiciary monitoring, reviewing, following, it may be safe. But actually, as this is synthetic, actually the synthetic disease modifying drugs, and you already know that it blocks the intracellularly the JAK-STAT pathway. So adverse event is actually common. So a person, rheumatoid patient, round the year will be good without infection is very unlikely. So the good follow-up and educate the patient and good hygiene maintain. So another thing, we have always think for the remission. So as we have a target to the remission, so but there is a guideline tells this if we add baricitinib with the methotrexate, which drug or NSAID steroid, which drug we actually reduce? The biologics or disease modifying actually the last. The first NSAID or a steroid, then the MTX, then ultimately the baricitinib, the dose reduction, then the reduce. So baricitinib or the tofacitinib, whatever you use, actually this slow tapering and the lately actually off with the until unless any active infection or TB or like this, or the malignancy or any neurological emergency.
Thank you, sir. Sir, one of our participants, Dr. Aniruddha Mandal, if the disease is controlled with JAK inhibitor, how we will withdraw the drug?
So actually drug withdrawal, because baricitinib is not a first line drug. We should as a first monotherapy, then double, then triple, then if not, maybe you can use the combination, first steroid or then the oral biologist, and that means top our baricitinib. But in that case, I already assume the patient have a high DZT score that cannot be managed by triple therapy. So in that case, usually we cannot quickly omit the baricitinib or tofacitinib until unless any acute contraindication. That means suppose pregnancy, suppose any surgery, suppose any multiple sclerosis or the any developing GBS. Like without this, actually, we have to wait for the remission and wait for the remission, and this remission should be the maintained. Then we have to plan for the dose tapering. Then estimate that it may take years.
Sir, one of our participant asks about what should we do in follow-up of baricitinib.
Actually, the follow-up should cover the history, clinical examination, and the routine checkup, liver function test, renal function test. But the extra I want to say that means the lipid profile should be monitored 6 monthly and yearly chest X-ray. If there is any TB flare up, and any if suppose আমি যেমন বলি রোগীকে আপনি যদি কোনো সময় ফোড়া, পুজ, ডায়রিয়া, কাশি বা এখন কোভিডের মতো গলা ব্যথা হলো, এরকম কোনো সিচুয়েশন হলে ইউ শুড স্টপ। তো এই ধরনের দিকে যদি আমি না করতে পারি তাহলে কিন্তু তাহলে পেশেন্ট কিন্তু দ্রুত খারাপ হয়ে পেশেন্ট এক্সপায়ার করতে পারে। হ্যাঁ, আমার এরকম এক্সপেরিয়েন্স আছে অন tofacitinib। আমি মনে হয় আমি আমার পেশেন্ট about 15 to 20 I have to manage pneumonia, and when there is a pneumonia occurs, I stop that tofacitinib and do not continue. I have to switch over the another drugs. I never, because একবার নিউমোনিয়া হয়ে গেলে ওটা তো লাংসে ফাইব্রোসিস হয়, ড্যামেজ হয়, প্রবলেম হয়। এবং যারা স্মোকার, যারা ডায়াবেটিক, যারা আগে থেকে ইমিউন সাপ্রেসড, যারা ব্রঙ্কিয়াল অ্যাজমা পেশেন্ট, সিওপিডি, তাদেরকে এগুলো না দেওয়াই ভালো। এটা আমার সাজেশন আর কি। আর যাদের থ্রম্বোএমবোলিক ম্যানিফেস্টেশন আছে, যাদের হার্ট ফেলিওর আছে, তাদেরকে একদম নিষেধ করা হয়েছে, এইগুলো আমরা দিব না।
Thank you, sir. Sir, a participant is willing to know about the in terms of safety measures, which one will be good to use, tofacitinib or baricitinib?
আমি অলরেডি আমার ডাটা আমি দেখিয়েছি, there is no superiority tofacitinib baricitinib, বাট আমি যদি মেকানিজম অ্যাকশন দেখি তাহলে আমি কিন্তু দেখছি যে tofacitinib একটু বেশি ব্লক করছে সেটা, এবং আমরা এটা চাই না যে এত বেশি ব্লক হলে আমার ন্যাচারাল সিস্টেম টোটালি ব্লক হয়েছে। আমি মানে আমার এনভায়রনমেন্টের সব অ্যান্টিজেন আমার শত্রু হয়ে যাবে, আমার এই ডিফেন্স সিস্টেম কিছুই থাকবে না। সো আমার মনে হয়েছে যে সেই দিক দিয়ে baricitinib is a little better, but time will say, because in our setup actually no study, আর বাইরের স্টাডি বলছে there is no superiority, but baricitinib may be, but এটা মানে খুব significant difference নাই, statistically no significant difference.
Sir, another participant willing to know about, can we use in the diabetic mellitus patient any effect on blood sugar level?
Yes, actually the uncontrolled, actually the chronic persistent uncontrolled rheumatoid patient, that actually affect the insulin resistant like this. But so far I know actually the drug itself do not hamper the diabetes or like this. But if the uncontrolled diabetic patient you want to treat, but this is very much risky, because uncontrolled diabetes with uncontrolled rheumatoid patient, there is maybe chance of stroke, atherosclerosis, thromboembolism. In that case, tofacitinib, baricitinib should not be used without controlling this comorbidity, because if you start, you actually, because this is a quick action, within 1 to 2 weeks baricitinib or tofacitinib actually come into action, whereas methotrexate, sulfasalazine, it may take 4 weeks or 6 weeks. So কুইক অ্যাকশন, একদিকে কুইক অ্যাকশন হচ্ছে, কুইক ইমিউন সাপ্রেশন হচ্ছে, আবার এদিকে ডায়াবেটিস আনকন্ট্রোল। তো সো এই জন্য আগে ডায়াবেটিস কন্ট্রোল করে বডিকে ঠিক করে তারপরে, আর এই মধ্যে যদি আমি এটাই সুযোগ থাকে আর কোনো চান্স থাকে, তাহলে এনএসএফ দিয়ে শুরু করা। আমি এনএসএফ দিয়ে অবস্থায় আমি 2 সপ্তাহ ম্যানেজ করলাম উইথ দ্য endocrinologist or the making the team, then we can plan if এটা ক্রাইটেরিয়া যদি সেট করে যে আমার ট্রিপল থেরাপি হচ্ছে না অথবা হাই ডিজিজ অ্যাক্টিভিটি, then we can go through the baricitinib, because biologists to সবাই avail করতে পারবে না।
Thank you, sir. One of our participants asked a question to our chairperson, Professor Dr. Soleiman Ma'am, that should we stop JAK inhibitors before surgery? Ma'am, please answer the question by unmuting.
Unmute করতে হবে।
Professor Soleiman Ma'am, please unmute yourself and answer the question.
Thank you, Dr. Monir Jaman, but you haven't mentioned the side effects and contraindications of this tofacitinib or baricitinib. Those are the things that should have been mentioned. So when there is a chance of infection in surgery, so it is better to withdraw, depending what kind of JAK inhibitors he or she is taking. If it is possible during the surgery period and post-surgery, you can take it off and then again reintroduce. It is the surgeon's choice and depending on the patient's condition.
Thank you, madam. One of our participants, Dr. Masumuddin, want to know how you will treat adverse effects of JAK inhibitor like opportunistic infection and hematological toxicity. Munir Jaman sir, please answer the question by unmuting that how you will treat adverse effects of JAK inhibitor like opportunistic infection and hematological toxicity.
Thank you. Actually, the opportunistic infection তো অনেক জায়গায় হতে পারে। হ্যাঁ, এমন দেখা হলো যে পেশেন্টের নিউমোনিয়া হলো, পেশেন্টের ডায়রিয়া হলো, অথবা কোনো বয়েল কার্বানকেল হলো, সেলুলাইটিস হলো, ইভেন কি ভাস্কুলার থ্রম্বোফ্লেবাইটিস হলো, যেটাই হবে ফার্স্ট স্টপ দা টফাসিটিনিব অর বারাসিটিনিব, দেন ট্রিট অ্যাকর্ডিংলি। বিকজ যদি এখানে থ্রম্বোএম্বোলিক ফেনোমেনন হয়, শুধু এখানে অ্যান্টিবায়োটিক দিতে হবে, এখানে প্রোফাইলেকটিক না, এখানে থেরাপিউটিক লেভেলে আমাকে হেপারিন দিতে হবে। সো এখানে ক্ষেত্রে শুড মেক এ টিম অলওয়েজ। Patient, any opportunity infection, patient should be hospitalized for safety and do the all parameters initially and make a team, maybe the rheumatologist, internist, or the vascular surgeon, or even the surgeon, because patient may have a diverticulitis, maybe with ischemic colitis, many things. Patient may have developed the pneumonia or the. এখানে আমি এই জন্য বললাম যে পেশেন্টের যখন যেটা হবে সেই অর্গান স্পেসিফিক আমাকে ট্রিটমেন্ট করতে হবে। এখন ইন জেনারেল এখানে বলা মুশকিল যে একটা কমন অপরচুনিটি ইনফেকশন, হ্যাঁ, এরকম বলা যাবে না। আর একটা হচ্ছে হেমাটোলজিক্যাল, যেটা সেটা হলো যদি লিম্ফোমা বা এই ধরনের কিছু হতে পারে, হ্যাঁ, সিভিয়ার অ্যানিমিয়া হতে পারে, তো সেই ক্ষেত্রে যদি আমাদের সাসপেক্ট করতে হবে যে একটা পেশেন্ট যখন আসে তো তখন যদি লিম্ফোপেনিয়া হয়, সাইটোপেনিয়া হয়, আমি তো বসে থাকবো না, আমাকে দেখতে হবে যে 4000, 3000, 2000, 1500, তো ফার্স্টে 3000 গেলে তো 3500 গেলে তো আমাকে মাইন্ডে সেট আপ হতে হবে কি ব্যাপার, প্যানসাইটোপেনিয়া বা সাইটোপেনিয়া হচ্ছে, তাহলে শুড স্টপ। যদি পেশেন্ট, অনেক সময় পেশেন্টই আসে না, বছর ধরে খেতে থাকে, এইসব পেশেন্টদের চান্স অফ লিম্ফোমা লিগমেন্ট যদি হয়েই যায় তখন তো শুড বি ক্যাটাগরাইজ ইনিশিয়ালি। এই জন্য চেস্ট এক্সরে, তারপর যদি লিম্ফ পাওয়া যায় দেন গো ফর বায়োপসি, দেন তারপরে অ্যাকর্ডিং টু চেইন তারপর সে আইদার হেমাটোলজি বা অনকোলজিস্টের কাছে যাবে। তো এইসব ক্ষেত্রে যদি আর্লি উইথড্র করা যায় তাহলে হয়তো রিকভারি ভালো আর কি, কিন্তু হয়ে গেলে তো তখন তো ট্রিট অ্যাকর্ডিং টু দা গাইডলাইন।
Thank you, sir. Now a participant who want to know about a question and he asks our Professor Dr. Munir Islam sir. Sir, please unmute first and I will ask you the question. Is there a clinically meaningful efficacious difference between the JAK inhibitors?
Please repeat the question.
Is there a clinically meaningful efficacy difference between the JAK inhibitors?
Actually, among the JAK inhibitors, tofacitinib has come first, and there is much data in that drug only. But the later two, baricitinib and upadacitinib, has came later. Baricitinib has got FDA approval on 2018, and the upadacitinib probably in the September last year. So we have very small, very limited experience on the later two and a comparative. But there are comparative studies. In the initial studies, as Moniruzzaman mentioned, the tofacitinib, we got the, in case of tofacitinib and upadacitinib was better efficacy of better in initial studies, better efficacy than over the baricitinib. But the combination therapy with the methotrexate shows the similar result in the three of the JAK inhibitors. But as Moniruzzaman also mentioned lately, that later there was even in monotherapy also there is less there is similar result with tofacitinib, baricitinib, and upadacitinib. But initial studies, but I think in case of later two molecules, we have to see much more data for a final comment. So, so far we have the practical experience. We have practical experience with tofacitinib only, but baricitinib we can consider because I have seen that it is almost 50% of the cost. Cost effectiveness is a matter in case of our country, and since there is in case of safety, these drugs are almost same. So we can consider baricitinib if in our practical experience also this shows good result, as we found with some cases with tofacitinib. Thank you.
Thank you, sir. Another participant want to know from the whole floor that this is the time of COVID pandemic, whether if a COVID patient continue the drug or newly diagnosed COVID patient continue the JAK or discontinue it. It is for everyone to answer, please, one by one, because he asked that in the whole floor. Thank you.
আমি বলবো
everyone সবাইকে স্যার কোশ্চেন করছে সাথে
এটা কিন্তু আমার প্রেজেন্টেশনে ছিল স্যার স্লাইডে
হ্যাঁ মানে it has been already mentioned actually যে if we consider individual, we should consider individual patient in this case. The patient who are already immunosuppressed, and Moniruzzaman also mentioned not only immunosuppressed patient, the patient who have previous lung disease, if they are immunocompromised and lung involvement may be worse in that case. So we should consider the individual patient. We cannot stop everybody with the but the patient who have no symptoms. So I think they may continue no symptom and no other history of complication or comorbidity. They may continue with it, but the patient who have such comorbidity or previous history or or already having lung involvement in a COVID due to COVID infection may be considered by the physicians, treating physician, to stop the drug. Thank you.
Thank you, sir. Associate Professor Monroe, sir, please add something or.
না না এটা আমি আমি একটু বললাম যে ম্যাডাম এখানে কিন্তু দেখেন এই যে জ্যাক ইনহিবিটর অ্যাডভার্স ইভেন্ট কিন্তু এখানে আমি বলেছি দ্রুত যে হেডেক, ডায়রিয়া, নশিয়া, ইটিআই, আপার রেসপিরেটরি ইনফেকশন আর নেজোফ্যারিঞ্জাইটিস এন্ড ইনফ্লুয়েঞ্জা। আর অন্যান্য জায়গায় কিছু জায়গায় আসছে যে থ্রম্বোএমবোলিজম আর হাইপারলিপিডিমিয়া বা ডিসলিপিডিমিয়া হতে পারে। আর এই 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 দুইটা জিনিসই আলাদাভাবে বলেছে আর কি। আর যেটা কোভিড এর ক্ষেত্রে যেটা বলা হচ্ছে সেটা হলো কোভিড এর ক্ষেত্রে আমি এখানে একটু আমি দেখিয়ে দিচ্ছি, সেটা হলো যে কোভিড রোগী কয়েক রকম হতে পারে। একটা হলো যে মানে সে প্যান্ডেমিক এরিয়াতে আছে কিন্তু সিমটম নাই, শুধু এক্সপোজার হয়েছে। তো সেই ক্ষেত্রে বলা হচ্ছে যে কি, যে এখানে শুধু হাইড্রোক্সিক্লোরোকুইন, সালফাসান, এনএসাইড এই কয়টা কন্টিনিউ করতে বলেছে, বাট স্টেরয়েড, জ্যাক এগুলো বন্ধ। এগুলো যেহেতু এক্সপোজার হয়ে গেছে, যদিও সিমটম নাই, সে কারণ সেই ইমিউনো সাপ্রেস থাকলে যে কোনো সময় কোভিড তার মানে ডিজিজটা স্প্রেড করতে পারে। কিন্তু রোগী যদি খুবই সিরিয়াস ইনফেকশন, লুপাস নেফ্রাইটিস বা ভাস্কুলারিটিস, তাহলে বলছে যে এখানে স্টেরয়েড হাই ডোজ স্টেরয়েড দিতে বলছে, এখানে দিতে হবে লাইফ সেভিং। আবার এখানে বলেছে যে ইন এসএলই ক্ষেত্রে হাইড্রোক্সিক্লোরোকুইন রাখতে বলেছে, বেলিমুভের কথা বলেছে। আর স্টেবল পেশেন্ট যদি উইদাউট কোভিড প্যান্ডেমিক এরিয়া হয়, যেমন আমাদের আমি ধরে নিলাম আমাদের রুরাল এরিয়াতে কোভিড প্যান্ডেমিক নাই, আরবান এরিয়াতে আছে, সেই ক্ষেত্রে প্রিভিয়াস ট্রিটমেন্ট কন্টিনিউ করতে বলছে। তাহলে আমাদের যেখানে যদি এখন ওয়ারি থেকে কেউ আসে, সেই ক্ষেত্রে আমাকে কিন্তু চিন্তা করতে হবে অনেক কিছু। আর কেউ যদি আসে একদম যমুনা পাড়ের থেকে, তাহলে আমরা অনেকভাবে সেফলি চিন্তা করতে পারি। এটা হলো মানে এটা বলেছে। আর একটা বলেছে যে যদি উইথ ইনফেকশন হয় কোভিড-19, তাহলে শুধু হাইড্রোক্সিক্লোরোকুইন কন্টিনিউ করতে বলছে, আর সব বন্ধ। আর মাইল্ড সিমটম থাকলে শুধু এনিসাইড রাখতে বলেছে, আর বাকি তাও আসলে সবই বন্ধ করতে বলছে, কারণ তাকে ভালো হতে সময় দিতে হবে। আর সিভিয়ার রেসপিরেটরি ডিজিজ হলে সবই বন্ধ, কিছুই থাকবে না। আর এখানে বলছে যে তারপরে আমি বন্ধ করে দিলাম, শুরু করব কখন? শুরু করার জন্য আমাকে করতে হবে কি, যে মাইল্ড ইনফেকশন হয় বা সেলফ কোয়ারেন্টাইনে ছিল, বন্ধ করা হয়েছে ড্রাগ, তাহলে 7 থেকে 14 দিন পরে রিকভারি অফ সাইন সিমটম, তারপর শুরু করতে বলেছে। আর যদি সিমটমেটিক পিসিআর পজিটিভ হয়, যেমন আমাদের অনেকেরই হয়েছে যে পিসিআর পজিটিভ কিন্তু সিমটম নাই, সেক্ষেত্রে বলেছে যে তখনও আমাকে বন্ধ করতে হবে জ্যাক ডিসমডিফাইং। কিন্তু বলছে যে আফটার পজিটিভ টেস্টের 10 থেকে 17 দিন পর তখন আমাকে রিস্টার্ট করতে বলেছে। আর সিভিয়ার ইনফেকশন হলে তারপরে ভালো হয়ে গেলে কখন শুরু করব সেটা বলেছে যে গ্রুপ ডিসকাশন করে আর এক্সপার্ট ওপিনিয়ন নিয়ে ডিসিশন নিতে বলেছে। এই হলো কোভিড।
আমি একটু জিজ্ঞেস করতে চাই,
হ্যাঁ হ্যাঁ,
যখন সাইটোকাইন স্টর্ম আরম্ভ হবে, ঠিক আছে, তখন কিন্তু আমরা টসিলিজুম্যাব দেই।
জি জি,
সাইটোকাইন স্টর্ম যখন আরম্ভ হয়,
হ্যাঁ
তখন কি আমরা এই জ্যাক ইনহিবিটর ইউজ করতে পারবো কিনা?
জি, আসলে সাইটোকাইন স্টর্মের জন্য রিকমেন্ডেশন আছে শুধুমাত্র টসিলিজুমের ব্যাপারে, ইন্টারলিউকিন 6 ইনহিবিটর। তো এবং এটা বলা হয়েছে যে এক্ষেত্রে বলা হয়েছে যে শর্ত হলো যে কোনো ইনফেকশন থাকা যাবে না। এখন একটা রোগীর ভাইরাল নিউমোনিয়া হয়েছে, তার ইনফেকশন হয়েছে কিনা আমি কিভাবে বুঝবো? তো বলা হয়েছে যে প্রোক্যালসিটোনিনটা টেস্ট করতে, যদি এটা বেড়ে যায় তাহলে তাহলে দেওয়া যাবে না। যদি যদি ব্যাকটেরিয়াল ইনফেকশন না থাকে তাহলে সাইটোকাইন টসিলিজুমেব দিতে বলেছে। এখন তাও বলেছে আর্লি, লেটে দিলেও রেসপন্স ভালো না। কিন্তু আর জ্যাক তো আমাকে সব ইনহিবিট করছে এখানে, কিন্তু এখানে সাইটোকাইন স্টর্মে বলছে শুধু ইন্টারলিউকিন 6 এর কথা বলা হয়েছে, যে ইন্টারলিউকিন 6 টা স্পেশালি এই সাইড এইটাই বাড়ে বেশি। এই জন্য মানে টপাসিনি বা জ্যাকনিপ এগুলো আসলে সাইটোকাইন স্টর্মের ক্ষেত্রে, স্পেশালি কোভিড এর ক্ষেত্রে বলা হয়নি, শুধু টসিলিজুমের কথা মানে ট্রিটমেন্ট গাইডলাইনে আসছে।
কিন্তু আমরা জানি যে তোমার যখন তুমি বলেছো প্রো ইনফ্লামেটরি মেডিয়েটরস সাইটোকাইন স্টর্ম যখন হবে, তখন তোমার টিএনএফ আলফা, ইন্টারলিউকিন 1, ইন্টারলিউকিন 6 সবই মানে বাড়বে। এবং ওখানে তুমি দেখিয়েছো যে ইন্টারলিউকিন 6, 9, 13, 23 এগুলি হলো আমাদের প্রো ইনফ্লেমেটরি মেডিয়েটার্স। এই সাইটোকাইনস গুলি বাড়ার ফলে আমাদের মেইনলি তোমার যে ইয়ে স্ট্রমটা হচ্ছে, আমাদের সাইটোকাইন মানে স্ট্রমটা হচ্ছে। হ্যাঁ, সুতরাং সেই মুহূর্তে সাইটোকাইন স্ট্রম আমরা মানে যদি দেখি তখন তো তোমার এটা মনে হয় টসিলিজুমাব ছাড়া অন্য কোনো জ্যাক ইনহিবিটর অথবা এই জিনিসগুলো কি ব্যবহার করা যায় কিনা?
এইখানে স্যার একটা কথা, সেটা হলো যে টসিলিজুমাব দেওয়া হচ্ছে, সেটা কয়বার দেওয়া হচ্ছে? অনলি 2 বার। মানে একবার দিয়ে 12 ঘন্টা পরে আরেকটা, সেকেন্ড, শেষ, আর দিচ্ছে না। মানে এইটা একটা মানে সাডেন একটা মানে স্ট্রমকে একটু ঠেক দেওয়া। কিন্তু আমাদের যে টফাসিলিন বা জ্যাক এগুলো তো আমরা কিন্তু ইউজ করতেছি একটা ক্রনিক একটা রিমার্ডার ম্যানেজের। আর একটা হলো ইনফেকশনের ক্ষেত্রে একটা কথা আছে, সেটা হলো ইনফেকশনে এটা তো কন্ট্রাইন্ডিকেটেড। তো আমি যদি সাইটোকাইন স্টর্ম উইদাউট ইনফেকশন হতো তাহলে ঠিক আছে, আমরা উই ক্যান ট্রাই বা ট্রায়াল। বাট এখানে অলওয়েজ চান্স অফ ইনফেকশন দেখা গেছে যে কোভিড এর ক্ষেত্রেও দেখা গেছে যে সাইটোকাইন স্টর্ম মধ্যে ভালো হওয়ার পরেও রোগী পরে এক্সপায়ার, স্টর্ম চলে গেছে, সিআরপি নেমে গেছে, কিন্তু পরে রোগী এক্সপায়ার করে গেছে। এরকম পরে বলা হয়েছে যে সেকেন্ডারি মানে আপনার নজোকোভাইরাল ইনফেকশন ফ্লেয়ার আপ করছে ওদের, যেহেতু এটা ইমিউনো সাপ্রেশন হয়ে যায়, ফ্লেয়ার আপ করে ওইটা ম্যানেজ করা যায়নি। এগুলো মানে আমি বেশ কিছু ওয়েবিনারে অ্যাটেন্ড করেছি, তখন তারা বলেছে।
Thank you, Honorable Chair, Speaker, and I'm Dr. Noor Jawan Khondokar. I have some query to you. Can I proceed?
Yes.
Okay. Actually, for treating the rheumatoid arthritis, we know the conventional disease-modifying drug. The anchor drug is the methotrexate, MTH. So the first generation target synthetic biologics DMARDs, that is tofacitinib or baricitinib. In that situation, is there any clean-cut choice that we should proceed for tofacitinib or we should proceed for baricitinib? This is number one. And my second question is there any landmark when we should stop the JAK inhibitor? Like we know in case of methotrexate, there are some landmark, hemoglobin, serum creatinine, SGPT, and especially lymphopenia, pancytopenia, thrombocyte count, or WBC count. There are definite few landmarks that in that situation we should stop the methotrexate. So is there any such kind of landmark to stop the tofacitinib or the baricitinib? And thank you all.
থ্যাংক ইউ ডক্টর নুরুজ্জামান। তো অ্যাকচুয়ালি প্রথমে যেটা প্রশ্নটা করা হয়েছে যে সেটা হলো যে কখন মেথোরেসের যেমন আমরা শুরু করছি অ্যাজ অ্যাঙ্কর ড্রাগ হিসেবে, কিন্তু আমরা কখন বারিসিনিব শুরু করব? এটা কিন্তু আমরা কিন্তু আগেই বলেছি যে আমরা ট্রিপল থেরাপির পর নেক্সট চয়েস বলা হয়েছে যে আমরা যদি মনোথেরাপি তারপরে ম্যানেজ হচ্ছে না, তারপর আমরা সেকেন্ড থার্ড ড্রাগ হিসেবে সালফাসালিন বা হাইড্রোক্সিক্লোরোকুইন দিচ্ছি। তারপরে যদি হয়ে যায় তো কন্টিনিউ, না হলে বলছে শর্ট টাইম স্টেরয়েড দিতে বলছে। তারপরেও হলো না, গো ফর বায়োলজিক্স। এখন আসতেছে বায়োলজিক্সের সময়, এই যে টার্গেট সিনথেটিক আমি ডিমিয়াস দিব কিনা। তো এই বায়োলজিক্সের ক্ষেত্রে আমার এখানে আমাদের যে এখানে ইকোনমিক স্ট্যাটাসটা চলে আসবে এখানে কন্ডিশন, যে আমার এই রোগী কি আমার টসিলিজুমাব দিতে পারবে, আমার এই রোগী কি ইটারসেন দিতে পারবে, না আমার রোগী টফাসিলিজুমাব বারিসিলিন নেবে। যেহেতু এখানে DAS28 মোর দেন 5.1 হয়ে গেছে, বা এটা মোর দেন 1 মান্থ 2 মান্থ পারসিস্টেন্ট মোর দেন 5.1, তো সেই ক্ষেত্রে আমি যাইতেই পারি আমি বারিসিলিন টফাসিলিন রেখি। এটা হলো আমার একটা মানে কিন্তু এই সব ক্ষেত্রে এখানে কিন্তু ডাটা ট্রায়াল গুলো খুব মজার ট্রায়াল আছে। এখানে সব জায়গায় বলেছে যে মেথোরেসের গ্লুকোকর্টিকয়েডের সাথে কম্বিনেশনের সাথে মানে স্টেরয়েডের সাথে অন্য কম্বিনেশনে কোনো ট্রায়াল নাই। মানে সব ট্রায়াল গুলো আছে একটা ডিসমডিফাইং ড্রাগ করছে আর মেথোরেসের আলাদা। মানে উপরের লেভেলের ড্রাগ গুলোর সাথে কোনো হেড টু হেড ট্রায়াল নাই এক্সেপ্ট অ্যাডালিউমেন্ট। তো এই যে এগুলো করছে হয়তো বা কিছু কোম্পানির কিছু প্রবলেম আছে বা তাদের নিজস্ব এজেন্ডা, তাদের তো বিজনেস পলিসি ফ্যাক্ট থাকতে পারে। তো এই জন্য ডাটাগুলা যে যার লাইনে, যখন বায়োলজিক্স সব চলে আসছে তো 5.1 এইখানে ফিজিশিয়ান চয়েস, যে পেশেন্ট আমার পেশেন্ট পারবে কিনা, তারপর পেশেন্ট অ্যাফোর্ডেবিলিটি, তারপর মানে সার্চিং দা এনি পেশেন্টের মানে ওয়েট, পেশেন্টের কন্ডিশন। যেমন আমি বলেছি যে বাবা হতে চাইলে কিছু দিতে পারবে, প্রেগনেন্ট হলে কিছু দেওয়া যাবে না, এটা আপনারা জানেন যে টফাসিনে বায়োসিন কিন্তু প্রেগনেন্ট মাকে দেওয়া যাবে না। ওইসব ক্ষেত্রে তখন আমাকে ডিসিশন নিতে হবে যে কোনটা আমি দিতে পারবো কি দিতে পারবো না। আর সেকেন্ড কোশ্চেনটা যেটা বললে যে মেথরেসের কখন বন্ধ করে যেরকম আছে, এইটা বায়োসিনের ক্ষেত্রে এইভাবে না বললেও আসলে সব ড্রাগগুলো কিন্তু এভাবে আসছে যে যে সাইটোপেনিয়া বা দেখুন এজিপিটি যদি 120 এর উপর বেড়ে যায়, কোন ডিসমডিফাইং ড্রাগই তো বলা হয় না যে এটা কন্টিনিউ করা যাবে। আলটিমেটলি ইন জেনারেল যদি লিভার ফাংশন টেস্ট এরকম বর্ডার লাইন ক্রস করে যায়, রেনাল ফাংশন টেস্ট যদি, যেমন আমি বলেছি এখানে লেস দেন 60 নিচে গেলে বায়োসিন এখানে অফ করতে বলেছে। রেনালের ব্যাপারে এখানে একটু বার এটা কম, আবার পেনিসিতে দেওয়া যাচ্ছে না। তারপর যদি যখন এনি ইনফেকশন হবে, শুধু হাইড্রোক্সিল ক্লোরোকুইন ক্যান বি কন্টিনিউ ইন ইনফেকশন পিরিয়ড। আর কিছু কিছু ক্ষেত্রে বলছে সালফাসালিন ক্যান বি কন্টিনিউ। আর অল সাইটোটক্সিক ড্রাগস ডিসমডিফাইং বায়োলজি শুড বি অফ ইন ইনফেকশন পিরিয়ড। এই জন্য টিউবারকুলার ইনফেকশন হলে আমরা কি করব? Stop the tovacinib, baricitinib, stop the biologics, but can continue switch over to the hydroxychloroquine sulfasalazine. But methotrexate আমি দিতে পারছি না। এই জন্য এইসব ক্ষেত্রে মানে আর বাকি যদি নুরজামান কিছু বলো তো বলতে পারো।
Thank you, sir. Here I want to add one thing. In case of tuberculosis, if the patient treating with the biologics, in case of tuberculosis, we have to give the treatment of the TB for initial phase 2 months, and at the same time after 2 months we have to start the concomitant biologics treatment also. And this is the some guideline also says that. And one thing I want to share here, in case of dyslipidemia, actually the tofa and baricitinib causes, both are causing the dyslipidemia, but tofa only increase the LDL and HDL. But baricitinib also, this is increased LDL, HDL, and TZ also. There's some basic difference. So one thing also in baricitinib is the JAK inhibitor. They inhibit the JAK1 and JAK2. But tofa is inhibiting the JAK1 and JAK3. It's mildly, and JAK2 is responsible for the erythropoiesis. That's why few studies are saying that if you consider the anemia, because all the biologics are potentially causes anemia. So if you consider anemia in that situation, and tofa is mildly superior than the baricitinib. There are a few studies in that regard, sir. This is all. Thank you all.
ইনফেকশনের ব্যাপারে একটু কথা আছে, সেটা হলো যে ল্যাটিন টিবি যদি হয় সেক্ষেত্রে বলছে 3 মাস আমরা যদি আইসোনাইজার ইভামেসিন দিব, অথবা বলেছে যে শুধু আইসোনাইজার দিব আমরা 6 থেকে 9 মাস ল্যাটিন টিবি। বা যদি অ্যাক্টিভ টিবি হয় সেক্ষেত্রে কিন্তু আমাকে ডিউরেশন শেষ করতে হবে 6 মান্থস বা ফাইন্ডিং হিসেবে যে করতে হবে। এখানে কিন্তু 2 মাস 3 মাস না। এটা একটু মানে আমাদের ট্রেনি যারা আছে, স্টুডেন্ট আছে।
Okay.
Thank you, sir. One of our participants wants to know about for tofacitinib, hemoglobin level has a role in initiation and follow-up. And is it same for baricitinib?
এটা তো আনসার দেওয়া হয়ে গেল তো, নুরজামান বলো তো এটা।
Thank you, sir.
I want to add something. If hemoglobin level is less than 8 gram per dl, then you stop the baricitinib.
এখানে অ্যানিমিয়া তো একটা ভাস্ট টার্ম। অ্যাকচুয়ালি যদি মনে করেন, আমরা তো একটা খেয়াল করতে হবে যে অ্যানিমিয়া কি শুধু ড্রাগের জন্যই হয়েছে? আমাদের রোগীরা কিন্তু দেখা যায় হেলমিনথেসিস আছে, বা রোগী দেখা যায় ক্রনিক তার আয়রনিসিয়ানিমিয়া ডিউ টু পাইলস অথবা মেনোরেজিয়া, এগুলো ফ্যাক্ট কিন্তু, অথবা আগে থেকে ম্যালনারিস্ট
করতে পারে, মানে রিউমাটয়েড আর্থ্রাইটিস ইটসেলফ মানে ডিজিজ, মানে অ্যানিমিয়া অফ ক্রনিক ডিজিজও হতে পারে আর কি। হ্যাঁ,
যদি রিউমাটয়েড যদি আনকন্ট্রোল থাকে অনেকদিন, তাহলে ডিজিজ ইটসেলফ ক্যান কজ অ্যানিমিয়া। আমি বলছি যে লিভার হ্যাপিসিটিনিব তৈরি করে, সেটা অ্যানিমিয়া করতেছে, হিমোগ্লোবিন কমাচ্ছে। তো কিন্তু এইগুলো হলো যদি সব প্যারামিটার ট্রিট হয়ে বসে আছে, অথবা দেখলাম আমরা ফেরিটিন স্টোর কম, তো এইসব জিনিসে মানে দেখার ইস্যু যে একটা অ্যানিমিয়া হলে আমি শুধু বন্ধই করব অথবা আমি ট্রিট করব কিভাবে। তো সেইটা ওইভাবে অ্যাকর্ডিং টু কজ ফাইন্ড আউট তারপরে আমাদেরকে ট্রিট করতে হবে।
কিন্তু স্যার
আমি একটু অ্যাড করতে চাই। তুমি বললা আমরা তো প্রথমে যখন আমরা স্টার্ট করি তার আগে আমরা সব প্যারামিটার গুলো দেখতে হবে আমাদের, যে লিভার ফাংশন টেস্ট, কিডনি ফাংশন টেস্ট অ্যান্ড সিবিসিএস আর হিমোগ্লোবিন পার্সেন্টেজ, এগুলো দেখেই তো আমরা আরম্ভ করব। যখন আমরা বায়োসিটিনিবটা ইউজ করব, বায়োসিটিনিব ইউজ করে আমরা দেখতে পারলাম যে মানে সামথিং রং, দ্যাট ইজ অ্যানিমিয়া 8 গ্রাম পার ডিএল এর নিচে নেমে যাচ্ছে, অথবা ইজিএফআর কমে যাচ্ছে, অথবা তোমার দেখা যায় এসজিপিটি বেড়ে যাচ্ছে, তখন তো আমরা দেখি তো আমরা সেটা বন্ধ করতে যাব। এখন আমরা এটা প্যারামিটার কি, যেমন প্যারামিটার হচ্ছে হলো 8 গ্রাম পার ডিএল এর নিচে হিমোগ্লোবিন যদি নেমে যায়, যদি ইজিএফআর যদি তুমি বলেছো 60 উপরে না, এটা হলো 30 to 60 হলো মডারেট, 30 নিচে যদি নেমে যায় তুমি বন্ধ করে দিবা ইজিএফআর। এসজিপিটি যদি তোমার 3-fold বেড়ে যায় তখন তোমার বন্ধ করে দিতে হবে। আর সাথে সাথে আরো কিছু আছে, অ্যাক্টিভ ইনফেকশন, দ্যাট ইজ হার্পেস সিমপ্লেক্স, হার্পেস জোস্টার, শিঙ্গেলস, রেসপিরেটরি কোনো ইনফেকশন হতে পারে, কার্বানকেল পারাঙ্কেল যেগুলো হয়, তাহলে তুমি সাথে সাথে বন্ধ করে দিতে পারবা। এই জিনিসগুলো আমাদের একটু মানে খেয়াল রাখতে হবে। ঠিক আছে মনির, আর কিছু অ্যাড করতে চাও?
এখানে একটা পয়েন্ট মনে হয় স্যার একটু অ্যাড করা দরকার ইন কেস অফ হিমোগ্লোবিন কনসেন্ট্রেশন। মিথোট্রেক্সেটের ক্ষেত্রে হিমোগ্লোবিন কনসেন্ট্রেশনটা কিছু অথর কিন্তু 7 পর্যন্ত বলতেছে, 7। আর বাট এই জ্যাক ইনহিবিটরের ক্ষেত্রে একদম স্ট্রিক্টলি বলা আছে যদি 9 এর নিচে ফল হিমোগ্লোবিন কনসেন্ট্রেশন নেমে যায়, ইউ শুড স্টপ দা জ্যাক ইনহিবিটর।
Thank you, sir. Professor Shahzad Ripon, sir, please, can we add something to our presentation?
স্যার আনমিট করতে হবে।
Host, please unmute.
Please unmute yourself, sir, please.
Unmute হয় নাই। এখন
হ্যালো, শোনা যাচ্ছে?
হ্যাঁ শোনা যাচ্ছে, একটু জোরে বলো।
হ্যালো,
হ্যাঁ
হ্যালো, শোনা যাচ্ছে?
শোনা যাচ্ছে। হ্যাঁ
শোনা যাচ্ছে স্যার।
হ্যাঁ, I would like to thank Dr. Mohammad Moniruzzaman for his brilliant presentation on JAK inhibitor management of RA update management. So I thank also the all the
খুব আস্তে শোনা যাচ্ছে।
Hello, শোনা যাচ্ছে? All panel
শোনা
of
যাচ্ছে স্যার।
expert, Professor Mohammad Monirul Islam, Professor Dr. Jahidul Islam, and also Chairperson Professor Sohaili Rahman Madam, and also Professor Dr. Muzaffar Ahmed. I thank all the participants who are connected this webinar today. Today, I think that rheumatoid arthritis is a common inflammatory arthritis. Today, we in the treatment of rheumatoid arthritis paradigm is shifted. Earlier, it is said by Dr. Moniruzzaman the treatment is symptomatic, but along it is after that the target is to reduce the disease activity. But now the target is to remission. So there is available drugs. The main way of drug treatment is the DMRs. There is we have conventional synthetic DMRs. We have biologics. We have target specific DMR. Along with we use steroids and NSAIDs. in that when we start this DMR, we already know, but this JAK inhibitor we use in case of ACR guidelines. We use this JAK inhibitor when after conventional DMR with methotrexate monotherapy or combination therapy or triple therapy, then we do not achieve the remission or low disease activity. Then we add biologics, TNF or non-TNF, either one. But when these biologics is failed, then they recommend to use this JAK inhibitor. Euler also, but Euler also similarly, when conventional DMR are failed with triple therapy or combination therapy along with steroid, then we start biologics or tofacitinib. But in France guideline, it is nowadays due to some promising study on JAK inhibitor, and also it is low cost. That tofacitinib nowadays is recommended in France guideline. It is recommended after when the conventional DMR with triple or with steroid is failed, then we can start tofacitinib. Then we start biologics. So these are the situation about JAK inhibitor, especially tofacitinib have long-term study up to 9.5 years study, safety study. So it has long-term study. But in case of baricitinib, it has only 2 years or something more study. So we have more study on tofacitinib. So I think that tofacitinib is more more knowledge about tofacitinib. So we prefer tofacitinib. But in case of when it is cost effective, in case of baricitinib, I think it may be considered. But when there is previous any infection, severe infection history, I think it is better to not start biologics or especially JAK inhibitor if there is any severe infection. But I have some such situation because I start JAK inhibitor and then she or he got severe infection thereafter. So when there is, we must know about the previous severe infection history of the patient before starting JAK inhibitor. We also same guideline to start JAK inhibitor, which is for the biologics also. That is screening for TB and other vaccination and other things. But it is an ongoing process how the tofacitinib is safe. But now, up to now, it is recommended that all the precautions will be taken as biologics as before JAK inhibitors. As well. But it is now, there is a study going on. In future, it may be we use it without these precautions, especially TB and other screening. We must do it, use it without screening in future, I think, because it is well-tolerated drug, especially without if she or he have not severe infection or immunocompromised or other severe comorbidities or other organ damage. In COVID situation, in earlier, it's recommended that in pandemic area, all biologics and the JAK inhibitors are, if he or she used it, it is stopped. And other conventional NSAIDs may be continued. Before any COVID infection, it is already said by Dr. Moniruzzaman, when COVID is infected, one patient is infected with COVID, all the DMR except hydroxychloroquine plus minus sulfasalazine may be stopped. So, and regarding NSAID, may be used, but paracetamol is preferable. Ibuprofen may be used. Steroid is also stopped because in case of COVID patient, in earlier stage, when a patient is infected, there is virus load is increasing viremic phase. This viremic phase, if there is GMR or there is steroid, it is viral load is increasing. So we must stop these kind of drugs if anything is there. And we start these steroids when there is sign symptom of especially cytokine storm by some investigation like CRP, ESR, procalcitonin, D-dimer, and ferritin, and LDS like things. When we start it with other clinical symptoms, when there is evidence of cytokine storm, that's time we use steroid and also use tocilizumab for single use or 12 hours after. We have a patient in our COVID unit. He is also a doctor. We use this tocilizumab because we think in COVID period there is he has some aggravating and there is serious conditions because he have high rise fever and then his lung is involved more than 50% and patient saturation is deteriorating. So we decide to use first time steroid, high dose steroid, then with our meeting, we decide to use tocilizumab. And when you use tocilizumab to reduce the unorganized immunological response or to reduce the cytokine storm, we are lucky that this is working and the patient is conditioned after giving tocilizumab. Patient condition is better after 24 hours. But we do not give him another tocilizumab drip. So I think that it is only for it is not comparable with other our DMR, CSDMR or biologics or JAK inhibitor. It is slow-acting drug which reduce the inflammation in chronic cases. But tocilizumab have the ability to reduce the acute infection actively. So it is conditionally recommended in trial basis in case of COVID patient, but it is not absolutely recommended in COVID patient. So this is one situation I think. In COVID, actually, the main treatment is low molecular weight heparin and heparin, that is anticoagulant. It is proven efficacy if we start, especially with comorbidities and other conditions who have serious diseases, and especially prodding and the steroid in case of late stages. It is, I think, working well and other things, but mainly that COVID treatment is symptomatic. So I think that it is a time-demanding discussion today, and all the things in case of rheumatoid arthritis, the main thing is the early diagnosis and then assessment of the patients initially and throughout the disease process, and select the drug according to the assessment result and appropriately. But how long these DMR are continued? Especially, it is recommended that DMR must continue lifelong. But in case of when patient is achieving remission, then phase by phase, we first reduce the biologics or target DMR, then we reduce the other conventional DMR. But one DMR, especially who tolerate the methotrexate must be continued. But JAK inhibitor, we have 9.5 years study, so we can use this tofacitinib up to 9.5 years and baricitinib up to the 2 years. But in case of biologics, we use it especially when we do not achieve the remission, or if it is needed, we reduce the dose, but it may be given up to lifelong also. So this is my comment regarding today's presentation. Thank you. Thank you for patience.
Thank you, sir. Honorable sir and ma'am, is there any more topic to add by anyone, please?
Hello.
Hello. Sir, I would like to hello, sir. আপনাকে স্যার দেখা যাচ্ছে না স্যার, ভিডিওটা অন করেন স্যার প্লিজ।
I don't know video.
না, ভিডিওটা অন করছে না।
Hello. Hello.
হ্যাঁ, দেখা যাচ্ছে স্যার।
Hello.
স্যার।
Oh, hello.
স্যার দেখা যাচ্ছে।
Yes, thank you. Thank you. I must insert some comment about this good presentation. I must thank Dr. Monojaman for his enthralling presentation about this water arthritis, and has a long discussion about the pathophysiology and rheumatoid arthritis, and the transition of treatment from one form to another form, and there is some change of armamentarium of treatment protocol in rheumatoid arthritis is increasing, changing day by day. So it's one change that they were using the JAK inhibitor, but that is JAK inhibitors. So it's a good discussion have been done by Dr. Monojaman. I must thank our panel experts, the chairman, Professor Dr. Rahman, Professor Dayud Rahman, Professor Ripon, has a long vast given a long speech about the management of this arthritis. Actually, it's one of the comorbidities of human being and affecting millions of patients throughout the world. And treatment armamentarium is changing day by day, ranging from MTX to balance to synthetic targeted DMRDs like JAK inhibitors or JAK inhibitors. Actually, JAK inhibitors are a global drug because it is act on the nucleus, and other agents like biologics, the only process receptors, but it is internally acting. That is DNA transcription. It inhibits the DNA transcription. That is, it inhibits the messenger RNA formation for pro-inflammatory cells, so formation of pro-inflammatory cytokines. So it inhibits the formation of messenger RNA by phosphorize the Kinase kinase enzyme. Phosphorize the Kinase kinase enzyme, the JAK enzymes. That is 7 enzymes in Kinase kinase, 7 enzymes. You know, JAK1, JAK2, JAK3, JAK4, tyrosine kinase, and JAK5A and JAK5B. The 7 enzymes of these Kinase kinase enzymes. One of these, but beneficial effect is that it is JAK1 and JAK2 inhibitor. But tofacitinib is initially approved by the FDA in 2012. It inhibits JAK3 and partially JAK1 and JAK2. But it stimulates the T helper 2 cell only. But in case of baricitinib, it only causes a sensitization of the T helper cell type 1. So there's some difference between the tofacitinib and baricitinib. But because tofacitinib is used in some other immunological conditions, psoriasis, and some lymphoproliferative disorders, also tofacitinib may be used. But in case of baricitinib, it's only FDA has recommended in 2000. Dr. Morris has said that 2018 FDA has approved. Prior to that, FDA disapproved in 2017. This drug was disapproved by FDA in 2017. Again, after seeing its safety profile and clinical improvement of these drugs, they have even approved in 2018 December. Looking the superiority of the baricitinib or tofacitinib, and many things have been described by Dr. Monojaman. It has scheduled drugs because it has come as norms of application of these drugs, like you have to vaccinate the people who will take this treatment with these JAK inhibitors, probably vaccinated, liver function, kidney function, and the other comorbidities should be assessed in a meticulous way. Even Dr. Nurjam has said that the hepatic profile, blood profile, and the lipid profile should be monitored very meticulously, because this because hyperlipidemia and hyperlipidemia, if when untreated, that may cause other catastrophe. So it is wisely assessed by the scientists, when these drugs to be used, because a successful transition from MTX to biologics to this genus inhibitors, but JAK inhibitors or JAK inhibitors. So I must full that nowadays we can use these drugs after long observation with starting from MTX and the combination therapies, these bridging therapies. If there's failed with this conventional DMRDs after combination therapies or monotherapies, then switch over to biologics. But biologics are so costly, like adalimumab, TNF alpha blocker, IL-6 blocker, even B-cell therapies. These costly items. Rather, if you go for oral targeted biologics like oral JAK inhibitors, these are much more affordable for the common or the poor peoples who cannot afford this biologics. But in it's a good treatment. See, in that case, we had a successful transition from the to these JAK inhibitors or JAK inhibitors. Which actually, it is not some potential hazards, like it causes immune dysregulation, immune dysregulation, prayer of tuberculosis, herpes zoster infection, pneumonitis, pneumonia, even some lymphoproliferative disorders like lymphoma may circulate with this use of these drugs. So it should be meticulously observed, all these parameters of the systems that are involved in the neurological condition. So at the conclusion, I might have a good option to tell that of course we'll use these drugs, but meticulous observation and physician's global assessment and patient's assessment also is needed to before starting these internally active drugs, because it action you must know it action DNA also DNA in the nucleus. It causes DNA actions over like it inhibit the messenger RNA formation. That is very important for promotion of pro-inflammatory cytokines. So we have to good in-depth study, in-depth knowledge regarding the use of this JAK inhibitors or JAK inhibitors to the patients of RA. And in COVID situation, many things have been described by the Professor Dr. Murujaman as a way to give. But it is to mild symptoms or pandemic era. If possible, we have to stop these drugs and look for the total pandemic situation of the area. But if it's immensely needed, immensely needed in some conditions, you may wait mild symptoms, but you must stop the moderate symptoms and the severe symptoms, like when many of the speakers told that cytokine storm syndromes is even critical conditions. Well, there's immune dysregulation, so you must stop these drugs, prefer drugs, and go for the conventional DMRDs like hydroxychloroquine or maybe use in case of RA. So this long tedious discussion have been done by Professor Dr. Murujaman, pathophysiology and other aspects very nicely. I appreciate for this long tedious discussion, and I appreciate thanks to Dr. Ripon for his speech, and Dr. Nurujaman for the convincing information regarding the hepatic profile and hematology profile. So that good discussion have been done by these participants, and participants has thrown so many questions, so very important, pertinent to the discussion, and perhaps they've been satisfied with this answer by the panel experts or even the speakers. Perhaps they will get a benefit from this. The questions will be solved. Lastly, I must thank Dr. Murujaman and the organizers to arrange such a good discussion about the RA and its treatment armamentarium that is changing daily or over yearly. It is changing. So we're expecting that more changes will come in the future, because more and more antibodies are coming coming to scenario that is early detection, that is done by the told by the Murjaman, that 1433 ETA and MBDA. These are newer molecules and antibodies to search for early detection of the cases and early early starting of the treatment. Because as early as we start treatment, we can as the progression of disease and erosion of the disease that is more vulnerable to for cartilage destruction and joint erosion. So early treatment is very important. So these antibodies will help in initiating early treatment. I hope. So at the fag end, I must thank the speaker for the rhetorical or ornamental presentation. I must thank the panel experts for their bearing the agonies for long tedious discussion, and my part I must thank for the patient's participation, hearing of the participants, learned participants. So this is all I can say. And at the, I must have a retirement for my speaking. And thank you everybody. Thank you everyone. Thank you moderator. Thank everyone for the patience hearing of my speech. Thank you very much.
Thank you, sir, for your inspiring speech towards everyone. Honorable sir and ma'am, our open discussion is finished. Now I would like to request to MD Jiaur Rahman, Deputy General Manager, Marketing from Delta Pharma Limited.
একটা কথা বলে দিই, হ্যাঁ আমি একটা একটু যোগ করি যে এখানে অনেকেই আসছে, এই জন্য এই জিনিসটা বলা দরকার। আমরা দেখছি আর কি, টোফাসিটিনিব আমাদের এখানে অনেক কোম্পানি নিয়ে আসার ফলে আমরা এমন অনেক প্রেসক্রিপশন পাচ্ছি যে মানে একটা পেশেন্টের আর্থ্রাইটিস বা ওই রকম একটা কিছু হইছে, সেটা অনেকে ডায়াগনোসিস করার সঙ্গে সঙ্গেই তারা মানে বিফোর গোয়িং ফর কনভেনশনাল ডিএমআরডি মানে তারা টোফাসিটিনিব প্রেসক্রাইব করছে। এবং সবচেয়ে আনফরচুনেট যে এই ড্রাগটা যে একটা পেশেন্টকে ইনফেকশনে ভালনারেবল করবে, কিংবা তার সে ইনফেকশনে ভালনারেবল কিনা, সেরকম কোমরবিডিটি আছে কিনা, সেগুলা দেখছেও না, সে সম্পর্কে পেশেন্টকেও সচেতন করছে না। এমনকি এটা দেওয়া রুটিনলি আমাদের যে ভ্যাকসিনেট করার উচিত, হ্যাঁ, যে কিছু এগুলো যেসব ভ্যাকসিন দেওয়া রিকমেন্ডেশন আছে সেগুলোও করা হচ্ছে না। তো আমাদের এখানে দুইটা বিষয় একটু করা দরকার। এটা অলরেডি আমাদের প্যানেল অফ এক্সপার্ট এবং আমাদের মানে আজকের যে বক্তা উনি খুব ডিটেইল এই বিষয়গুলো আনছেন, সেই জন্য তাকে ধন্যবাদ। যে আমরা যেন পেশেন্টদের সচেতন করি এবং আমাদের ডিউটি হচ্ছে ডিউরিং দ্য ফলো আপ, একটা রোগীকে যথেষ্ট সময় দিয়ে তার এই বিষয়গুলি ডেভেলপ করে। ফলো আপের সময় শুধু ইনভেস্টিগেশন না, তার অন্য ক্লিনিক্যালিও এবং অন্য ইয়ের ক্ষেত্রেও তার মধ্যে এইগুলি ডেভেলপ করছে কিনা এই বিষয়টা দেখা হচ্ছে আমাদের একটা দায়িত্ব। তো এটা আমরা অনেক ফিজিশিয়ানদেরকে আনফরচুনেটলি করতে দেখছি না। তো সুতরাং আমরা যেন অ্যাডিকুয়েটলি মানে ফার্স্ট লাইন ড্রাগ ট্রাই করার পরে তারপরে যেন এগুলাতে যাই, বোথ ফর কস্ট অ্যান্ড সেফটি। এগুলার বেশি দুই দিক থেকে এটা আসলে নেগেটিভ, এটা কস্টও বেশি, সেফটি। কিন্তু যাদের ক্ষেত্রে ফেইল হচ্ছে তাদের ক্ষেত্রে এটা একটা আশার বিষয়, এটা আমাদের মনে রাখতে হবে। কিন্তু আমরা মানে খুব ড্রামাটিক রেসপন্স পাওয়ার উদ্দেশ্যে যদি এগুলি প্রিম্যাচিউরলি প্রেসক্রাইব করতে থাকি, সেটা খুব আনফরচুনেট হবে আসলে। থ্যাংক ইউ।
আমি স্যারের সাথে আর দুইটা জিনিস যোগ করতে চাই। মনোথেরাপি মাইল্ড কেসে দেওয়া হবে, মডারেট সিভিয়ার কেসে মনোথেরাপির সাথে বারিসিটিনিব অ্যাড করা যাবে। নাম্বার 3, বারিসিটিনিবের সাথে কখনো বায়োলজিক্স অ্যাড করা যাবে না। বারিসিটিনিবের সাথে কখনো পোটেন্ট ইমিউনোসাপ্রেন্স যে ড্রাগগুলি আছে, এজাথ্রোপিন, সাইক্লোস্পোরিন, যখন মানে সাইক্লোস্পোরিন, এজাথ্রোপিন দেওয়া হবে তখন এটা দেওয়া যাবে না। নাম্বার 4 হলো কিছু কিছু ওষুধ আছে, অর্গানিক অ্যানায়ন ট্রান্সপোর্টার 3 ইনহিবিটরস, দ্যাট ইজ প্রোভেনিসিড। প্রোভেনিসিড যখন দেওয়া হবে তখন এই বায়োসিটিনের ডোজ অনেক কমিয়ে দিতে হবে। ধন্যবাদ।
হ্যালো হ্যালো
হ্যালো, হ্যাঁ শোনা যাচ্ছে?
hello I'm Dr. Muzaffar Ahmed.
জি স্যার।
I'm Dr. Muzaffar Ahmed.
জি স্যার।
I want to
Hello.
add some few points.
Sir.
Hello, can you hear
sir.
to me? Okay,
Sir.
I like to
Yes,
add
sir.
a few
Please,
points. Few points like I must have appeal to the companies, because the appeal to the companies to deliver these drugs only some selective areas or selective pharmacies, because you know that there's in quacks are using in some inflammatory conditions, quacks are using this tofacitinib, or they will in future they will use baricitinib. So I'll appeal to the companies to selective delivery of the drugs, because treatment algorithm, as it describes, that it should be only used by the specialist, not by the quacks. So it's responsible of the company to deliver the drug to only those areas where they will get the prescription from the specialist, not to rural areas. I must provide them to deliver this to rural areas, not to deliver this in rural areas, because there is chance of maluse of this drugs by the quacks. So because they will use as a simple anti-inflammatory agent. And regarding our spectrum of the baricitinib, no, it's only T1 helper cell. It is activating the T1 helper cell. It is signal transcription. There's this state signal pathway. Only T1 helper cell it is potentiating. But in case of tofacitinib, it has got T1 helper and T2 cells. So it's a relatively narrow spectrum only used in the so they have told that it can be more beneficial only for rheumatoid arthritis. But tofacitinib may be used in psoriasis, some lymphoproliferative and rheumatoid arthritis. Even it may be used in SLE. So it's something, there's dilemma of using this baricitinib over tofacitinib. And you know there's 31 trial of baricitinib. Out of this 31 trial have been done by the companies. 31 trial. Out of this, 4 of 6 phase 3 trial have been completed. So there is still some trial is waiting for in favor of baricitinib. So I must appeal that it should be cautiously used, and it should be delivered to those areas only available for the prescription of the specialist, and meticulous observation of the market by the providers is very warranted for the judicious use of the drugs. Thank you very much for giving me the opportunity to speak about the matter. Thank you very much.
Thank you, sir. Honorable sir and ma'am, is there any more topic to add by anyone, please? Otherwise, we'll go for the next session. Thank you, sir. Now I would like to request Mr. Ziaur Rahman, Deputy General Manager Marketing from Delta Pharma. Please present your session.
Thank you very much, moderator. Honorable Chairperson of this academic session, Professor Sohail Rahman, and today's speaker, Dr. Munir Zaman, and the most veteran and senior professors and doctors who are well-known professors and doctors of the country, and the viewers. Assalamu alaikum and very good evening. This is Ziaur Rahman, Head of Marketing, Delta Pharma Limited. On behalf of Delta Pharma, thanking you for participating of this fantastic seminar. Actually, this is a very good seminar, and Delta Pharma always encourage the knowledge-based promotion. So I have a very small presentation today about the very new molecule baricitinib. It's a very small presentation, so you will not be very bored with my presentation. So I'm sharing my screen here. Could you see my presentation?
Yes.
Yeah.
Oh, thank you. So it's a very small presentation. Actually, at the very beginning of the presentation, I would share Delta Pharma's contribution in the rheumatology and related disorder. Actually, the company started its journey with a very new product, methotrexate. You know, methotrexate 10 and 2.5. And then long after, the company introduced Rumaflex, hydroxychloroquine, and then JAK inhibitor, Tofacitinib and Tofacitinib. And recently, we have launched baricitinib for the first time in Bangladesh under the brand name of Baricit, and it is a product that we have made with a API from GMF grade API, which has been purchased from a MHRA approved manufacturing facility. So it's a very high quality product, and this is the building where this product is being manufactured. This is our factory, state-of-the-art facility, and this is inside view of the our factory. And these are some officers who are working inside the factory. And this is the commercial product of Baricit. You see, Baricit 2 milligram tablet. And what about the price? I would like to say some words about the price of the Baricit tablet. It is only 20 taka per tablet. Actually, the pricing strategy of Delta Pharma is very different from any other company, especially in case of chronic disease. We see many patients discontinued their treatment because of the treatment cost or affordability of the product. And we see, and if you recall the presentation of our presenter, there was a rickshaw puller whose earning is very minimum, and who cannot buy the biologic product, and even many times he cannot buy the oral product also. So just think about the situation of the rickshaw puller. If a tablet price is 50 taka or 60 taka per tablet, how he could buy the product? So thinking this situation, Delta Pharma always try to keep the price, especially the chronic care product, very minimum, and it is affordable. But what about the quality of the product? In case of lower price, some people think the quality is sacrificed, but this is absolutely wrong. If you consider the Delta Pharma's strategy, they keep their price minimum after keeping the quality of the product maximum. So it is our strategy, and the company is launched in 2004 with a motto: the quality product at an affordable price. We serve the quality product, but at an affordable price. The price must be affordable, but at the same time, the quality must be up to the mark. So we launched this product at 20 taka per tablet. Actually, it is a CSR campaign of the company. Actually, the business should not be the only business for a corporate house. So there should be some CSR. So it is our CSR campaign. We introduce many of our chronic care brand at an affordable price, and it is also at an affordable price. And that's all about my presentation. Finally, I would like to thank all of you for patient hearing, and I would like to thank all of the participants, especially presenter. That is a fantastic presentation. Everybody, I hope everybody enjoyed the presentation, and I would also like to thank the chairperson, Sohaili ma'am, and I would like to the senior professors who have participated with their experience, and that was a very lively presentation. And responding to the question of an appeal of Professor Dr. Muzaffar sir, we are not serving the medicine to the quack, and even we are not promoting the drug in the general practitioners even. We are only promoting the product to the specialist level, especially rheumatologist, medicine specialist, or internal medicine specialist, or the physical medicine specialist only. We are not promoting the product to the general practitioners. And in case of QAC, we never think about that. So this product is not available in all shops, only the big shops of the district level pharmacy shops. We are providing the medicine. So we are ensuring the concern of the Professor Dr. Muzaffar sir. So that's all about my presentation. Thank you all once again.
Thank you, Mr. Ziaur Rahman, for your presentation. we are getting near to the end of the session. Now, from expert opinion, now I would like to request Professor Dr. Jahidul Islam sir from our Physical Medicine and Rehabilitation Department, Dhaka Medical College Hospital, to give some valuable opinion regarding the presentation. Professor Dr. Muhammad Jahidul Islam sir. First,
thank you, Dr.
unmute, sir,
Arif. Everything is told, I think so. Thank you, Dr. Munir, for your nice and excellent deliberation. Thank you, Delta Pharma, for organizing such a CME program. I think you will, I will request Delta Pharma to continue such type of program in future. Thank you all for patient sharing.
Thank you, sir, your short opinion. Now I would like to request Professor Dr. Monur Islam sir, Head of the Department, Physical Medicine and Rehabilitation, Sir Salimullah Medical College Hospital, to give some valuable opinion.
Thank you, Dr. Ari. This is a very good opportunity for all of us to discuss about a very promising drug in hematology in recent years. First of all, I would like to thank the presenter today, Dr. Munir Jaman, who has very vividly and within a very short time covered almost everything about the new molecule. And this was a time when we were students. There was actually no disease modifying drug for rheumatoid arthritis, and we heard that there is no treatment of rheumatoid arthritis actually. But when we came for postgraduate studies, we see that the first line drugs like methotrexate and sulfasalazine and hydroxychloroquine is on the way of using, and it was very hopeful for us. But eventually, when we were practicing, we found that there are many patients who are resistant to the first line drug treatment and having a lot of misery, and so in the last 2 decades we found that biologics has came with much more hope for those patients. But unfortunately, there was two negative sides of biologics. Number one is safety, and number two is cost. This is very in case of our country, the cost is most important factor for many of the, for I will say the most of the patients. But when the JAK inhibitors came, we know about everything about its mechanism of action, but I think that the most hopeful side was the cost, as it was very costly. And another thing is already we have discussed that it is very dose is convenient, and administration is convenient. That is oral drug. But as I was telling a few minutes back, that this easy thing has a drawback also, that it was promoted by the pharmaceutical companies to all of the doctors, and I have found that many of us our colleagues are writing it, unjudicially prescribing it, and it has been prescribed as a first drug for a rheumatoid arthritis or any arthritis, even without knowing which type of arthritis it is. So there is this type of practice may cause side effects, adverse effects,
Disconnected. Connected.
Adverse effect as well. So I would like I am seeing the scenario of JAK inhibitors as a hope for the cause of the hope for the poor people who will need this patient. And if we consider tofacitinib and baricitinib is more promising in this aspect, that it is much cheaper than tofacitinib. So in this situation of pandemic, when we are losing our hope in many fields, this is a hopeful area. We can expect a better future of arthritis patient of Bangladesh with baricitinib. So I would like to thank Delta Pharma for arranging this meeting, as well as introducing the new molecule to our medical practice. Thank you. Thank you all.
Thank you, sir, for your opinion. Now, I would like to request Professor Dr. Syed Muzaffar Ahmed, sir, from the Department of Physical Medicine and Rehabilitation and Bangabandhu Sheikh Mujib Medical University, to give some valuable opinion regarding the presentation. Professor Dr. Syed Muzaffar Ahmed, sir. I would like to request Professor Dr. Syed Muzaffar Ahmed, sir, for giving some valuable opinion, please. I think sir left us. I think sir left us. Okay, now I would like to request Professor Dr. Shahad Hussain Ripon, sir, Vice Principal and Head of the Department, Physical Medicine and Rehabilitation Department, Shahid Sohrawardi Medical College, and the General Secretary, Bangladesh Society of Physical Medicine and Rehabilitation, to give some valuable opinion regarding the presentation.
Yes, me. Hello.
Hello. Ji sir. Ji sir.
শোনা যাচ্ছে?
Ji sir.
I think that I covered many things in my in discussion during panel during question session. It is in case of JAK inhibitors, it is good in a sense that it is oral form. If we compared it with biologics, it is easy to taken, and it is also cost effective, and it is also effective when biologics are failed. That we can use it after biologics is failed. We may use it this JAK inhibitor, tofacitinib or baricitinib. And regarding COVID,
এটা তোমার আমার কাজে না লাগলো তোমাকে এখন দিব না, কারণ তোমার এখন ঘুমের সময়।
hello.
Hello, sir. শোনা যাচ্ছে স্যার।
So, this in COVID situation, though in pandemic situation, biologics and JAK inhibitors are stopped to prescribe it, especially in case of new cases. But recent study shows that the biologics and tofacitinib have no effect on COVID-19. I think that in future days, it is reviewing by various international societies regarding their recommendation to hold it used in case of pandemic situation. I think that today's discussion is fruitful for our who are connected today, and I must thank Dr. Munirujzaman for presenting such a nice case extremely well and brilliantly. And I thank today's panel expert, especially Dr. Professor Mohammed, Dr. Mohammed Jahidul Islam, Professor Dr. Monirul Islam, Professor Dr. Muzaffar Ahmed, and also thanks Professor Soheli Rahman Madam to organize this session as a chairperson. And I also thank Delta Pharma to help this and organize this kind of seminar, which is beneficial of our of all who present today. So again, thank all the participants. Thank you.
Thank you, sir, for giving your opinion. Now, I would like to request our chairperson, Professor Dr. Soheli Rahman ma'am, for giving her valuable opinion and conclude the session. Thank you.
Thank you, Arifur Rahman, for your moderation. It is 15 minutes to 11, and a non-stop conversation could have gone further, but we are becoming sleepy and hungry, so we must stop now, or I have to speak less. Regarding this topic, it is a time-demanding topic, and as you know, Munirujzaman has nicely said about this topic. Nothing, no stone has been unturned. He has tried to also explain the different questions of the students and also the experts. And to my opinion, in a simple nutshell, I just want to say which one to choose, JAK inhibitors or biologics. JAK inhibitors are small molecules and they can be orally taken, and they are cheap, and they can cross cell membrane barrier, lipid cell membrane barrier. Whereas the biologics are high, they need injections, and then they cannot cross this bile lipid layer of cell membrane. So these are the two differences. And which one is better, tofacitinib or baricitinib? I would like to say that baricitinib is better than tofacitinib, because baricitinib have more effect on 1, 2, and also tyrosine kinase inhibitor. And whereas tofacitinib is only 1 and 2, but little effect on tyrosine kinase and 2 inhibitor. And side effects are very little in this baricitinib drugs, except some fewer side effects like as nausea, itching, and thromboembolism is a very crucial, because in COVID patient, thromboembolism will give added effect while giving this baricitinib, because as you know, stroke, pulmonary embolism, and many other, even anywhere there is coagulation. So if you use baricitinib here, there will be additive effect on coagulation, thromboembolism effect it has, and it may also cause GI perforation and others. Whereas tofacitinib is also the same, but it's a little expensive. I want to ask Jia Rahman, Delta, what is the cost of 4 milligram baricitinib? Is it present now?
Oh, no, madam. 4 milligram is not available in Bangladesh. It's a 2 milligram tablet, but 20 taka per tablet. 4 milligram is not available. We have to take 2 tablets if you want to take 4 milligram.
And I must also thank Delta Pharmaceutical. They're always with us, especially rheumatoid arthritis. As you know, they were from the start. They have started with methotrexate, and our brand drug is methotrexate. Whenever we write methotrexate, the first drug is our choice. And they're always trying to bring more and more latest recent drugs to help us to treat our difficult rheumatoid arthritis patient. Rheumatoid arthritis is a never-ending topic, and more research is going on every day. Maybe some days later there'll be something more to come. So I must thank our Delta Pharmaceutical, who has arranged this Zoom CME program through Raj TV. This is my first, I don't know, Raj TV, is it focusing on other parts? I don't know, but this is the first time I'm, talking on Raj TV. So, and they're always with us, and in future, we will get to know more about it, and more to come still to give our poor patients, especially, to have get remedy from this very difficult situation of rheumatoid arthritis. Thank you all. Thank you very much. Thank you. And
Thank you, Honorable Sir.
I want to also thank Dr. Shah, Professor Shahadat, Professor Monirul Islam, Professor Mujaffar Ahmed, and many more. And of course, the students who are, I cannot see them, they're the best participant of this evening. And I'm very happy that everybody is still awake and took great importance and took it seriously, this topic of CME. So thank you all. See you next time.
Thank you, Honorable Sir,
madam.
ma'am, for sharing everyone's experience about JAK inhibitors. Thank you, Delta Pharma, for arranging such a nice CME program on a webinar. Thank you, Raj TV, for broadcasting in on live on Facebook. Thank you.
Thank you.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.